little bit. I know folks are coming in. So what we like to do at the beginning of our coffee chats is introduce a new CEO in the community to the community. And then I also really like to feature folks who are new to the call or new to the Alliance world. And so Jessica, you know, I'm going to ask you to say hi to everyone. So, but first and foremost, thank you so much for joining us today. It is my pleasure to kick us off today with a warm CEO welcome for Michael Perlmutter, who is the new CEO for the EveryLife Foundation. You joined the organization just a few weeks ago on March 28th. So you are even newer than our new CEO, John Crowley. But Michael comes to us from the Cerebral Palsy Alliance Research Foundation, and after 13 years there. And he and our new CEO, John, met yesterday, and they have common roots in the Naval Academy, but also in their dedication and commitment to the rare disease community. So, Michael, we look forward to hearing all about what you envision for EveryLife Foundation and some of the experiences that you bring both personally and professionally as a member of the rare disease community. So I'll turn it over to you.
Thanks, Michelle. And to everybody, it's a pleasure to meet you here. I apologize for my voice. As Ted from my team who's on this call knows, I have 3-year-old twins, and whatever they come home sick with, I get sick with. So I apologize a little bit for that. As Michelle said, my name's Michael Perlmutter. I come from the cerebral palsy space, where I ran an organization focused on research and innovation. And before that, I ran another research organization that's the world's largest for performance-enhancing drugs in sport. But it was actually an incredibly personal event that brought me to EveryLife. So in 2022, April of that year, I was diagnosed with a rare disease myself. I went to a routine doctor's appointment, saw some bad numbers, and was in a follow-up appointment told that I had a terminal form of blood cancer. And for 6 weeks, my family, much like many other families, went through the struggles of trying to figure out whether that was the actual diagnosis, whether what was going to happen to my 1-year-old at the time twins, and my wife and my family. And then I did what many people do, and I searched PubMed and the internet for the experts in the specific type of blood cancer that I have, and it turns out it isn't terminal. And in fact, there is a treatment. I am one of the 5% of people with rare diseases that have an approved treatment. It is a repurposed drug that I take twice a day. And I realized that that drug was only available to me because of people that worked in the rare disease space. And I wanted to see whether or not this was something that I could pay it forward for the rest of the community. And so, as Michelle mentioned, I joined EveryLife. It was actually April 1st, so I'm even newer than Michelle mentioned. But I tell this story because I had never told my rare disease story before I interviewed for the position of EveryLife. And in a way, it's the most apropos thing that I can say about EveryLife, because as an organization, we exist to give people a voice. And before I was even here, EveryLife gave me a voice. It enabled me to speak about my rare disease. It enabled me to process some trauma that I was not able to process myself. It enables my family to be stuck with me for the rest of my life, and me the opportunity to grow up and watch my now, as I mentioned, 3-year-old twins go to elementary school and way beyond. And so I've been here now for about 5 weeks. I am very much still in the learning phase. But as EveryLife celebrates its 15th year anniversary, I do have some stuff that I think is a priority for us. One of which will sound obvious, but we're embarking on a new strategic plan. For those of you that have worked with EveryLife, including Bio itself, we have accomplished a lot over our 15 years, but it's time for us to figure out who we want to be as, metaphorical teenagers in this space. And we're excited to do that with each and every one of you. So we're excited to engage other patient organizations. We're excited to engage the community more broadly. We're excited to hear other people tell stories like mine. But here are the things that we are going to prioritize. We are going to prioritize growing and expanding our mission to meet the needs of the community. We're going to depend on the community in large part to tell us what those needs are. But we are committed to that expansion. And we're going to, what I would like to call, optimize engagement across the ecosystem. So we are going to be good collaborators and good partners for anybody that wants to work together. We have lots of ideas what that could look like. It could look like new and innovative trial designs. It could look like the use of big data and AI to lessen the diagnostic journey. It could look at regulatory science so that everybody that is moving drugs through the pathway has a consistent experience. And so we are committed to that growth. We are committed to working with each and every one of you. And I now really enjoy telling my story. So I hope that I will get the opportunity to meet each and every one of you and to hear your reason for being involved in the rare community. I appreciate the opportunity to take about 5 minutes of your time, and I will turn it back over to Michelle.
Thank you so much, Michael. We are really looking forward to the continued partnership and certainly seeing you out at the Bio Convention. Again, just in the spirit of making some introductions, since we have so many patient advocates on the line, I want to make sure that you are meeting and greeting fellow industry contacts who are new to the space or new to their role. So Jessica, if you don't mind saying hello, and then I'm going to ask Ravi to do the same.
Sure. So, Michael, I'm also an April Fool's hire. I joined GSK on April 1st, and I joined from Ultragenics, who, as you well know, Emil was the founder of Every Life Foundation. So I have a big place in my heart for your organization. I'm leading the patient advocacy function for GSK, which covers a whole variety of therapeutic areas from chronic preventative medicines like vaccines, and then also disease, oncology and things in the rare space. So we have a pretty diverse portfolio, and I'm going from a company of 1,300 people to 70,000. So here I am back at Big Pharma, but really happy to see all of you and be part of this group. So thank you.
Of course. Welcome, Jessica, and you're welcome to put your email address in the chat if you want.
Sure.
So folks know how to reach you. Ravi Singh, who is at Bluebird, do you mind just saying hello to everybody on the line and introducing yourself?
Yes, Michelle, thank you so much for the opportunity. My name is Ravi Singh. I'm VP of Advocacy and Alliance Development at Bluebird Bio. I've been working at the company for about 5.5 years, but recently joined this role in the Advocacy and Alliance Development space. Prior to this role, I was leading our program team that was responsible for the approval of our sickle cell disease gene therapy, and also worked on our gene therapy for beta thalassemia requiring regular blood transfusions, as well as our portfolio includes a gene therapy for an ultra-rare disease, cerebral adrenoleukodystrophy. So really appreciate the opportunity to introduce myself to folks here, and I'll also drop my email in the chat.
Great, thanks. Anybody else who is new to the patient advocacy community or to this group, whether you're from a patient group or a company, feel free to you can put your information in the chat. Again, we really like this to be a networking opportunity for all of you. So with that, let us get into the discussion of the day, which is our favorite four-letter word, MDRP, the Medicaid Drug Rebate Program. And there is a lot to talk about here. So we will get right down to business. I will share that Jack Geiser is here from Bio's team, and he can answer technical questions that I absolutely cannot under any circumstances around the MDRP because it is so complex. But we will first hear from Brian Nyquist, who is President and CEO of the National Infusion Center Association, who will talk to us about sort of a provider perspective. And Brian, if you don't mind sharing a little bit of background on the MDRP and how it affects you all, that would be excellent.
Great. Thanks, Michelle. Good morning, everyone. As Michelle indicated, I'm Brian Nyquist. I'm with the National Infusion Center Association, which is a 501c6 nonprofit trade association formed to support and represent the nation's non-oncology, non-hospital, community-based infusion centers and their ability to support patients that rely on provider-administered medications to manage the physical, emotional, and financial burdens of complex chronic disease. So in the context of the MDRP, Medicaid best price is currently calculated based on the largest discount a manufacturer has available to any stakeholder in the supply chain. So if we talk about, say hypothetically $100 drug, that manufacturer gives a pharmacy a 30% discount and a GPO a 40% discount. Sorry, $30 discount or $40 discount. The Medicaid best price would be $60, right? Taking into account the biggest rebate, which is $40. What this rule would do is essentially change fundamentally how Medicaid best prices are determined. And it would ultimately force manufacturers to stack all of the discounts that they have. So under the new calculation, that best price would be $40, or excuse me, $30, because you add the $30 discount plus the $40 discount for a $70 discount on a $100 drug, which is a $30 cost. So it doesn't make a lot of sense, but ultimately what it's going to do is incentivize manufacturers to minimize the amount of rebates and discounts that they put into the market to minimize the impact and implications for their operations and their ability to invest in innovation. So manufacturer discounts and rebates are so deeply integrated into the healthcare system that supply chain and healthcare economics rely pretty heavily on them, particularly community practices and pharmacies, and especially infusion centers that are dealing with very expensive drugs. Infusion centers, as well as community pharmacies and other healthcare providers, rely on manufacturer discounts to retroactively reduce their drug acquisition costs so they can achieve a reasonable, albeit small, margin. Without these manufacturer rebates, community-based infusion centers in particular would no longer be able to operate in patients, not only Medicaid patients, but all patients, because the implications for these discounts extend beyond Medicaid patients. So all of these patients that currently rely on these medications would lose access to the most cost-effective setting for provider-administered medications in particular, which again are some of the most expensive medications and represent the last line of hope for patients, particularly with autoimmune diseases that have tried and failed, all other conventional treatment modalities. So NICA conducted some polling and research, which found that voters and supply chain stakeholders are concerned that the rebate stacking rule will force manufacturers to eliminate certain rebates and discounts from the supply chain, which carries significant implications for patient access, coverage, choice, and affordability. Ultimately, it doesn't matter how low we make the Medicaid best price or drug costs in general. If we lower costs at the expense of access, nobody wins. So based on this morning consult poll of over 10,000 voters, confidence that the rule will improve patient outcomes is weak, and people are concerned that if finalized, the rule could raise drug prices for all patients. After learning more about the potential unintended consequences of the rule being finalized, opposition to the rule increased notably. People ultimately feel that the rule will be harmful to patients, infusion centers, and the US healthcare system more broadly. Surprisingly, 1 in 5 adults indicated they would be less likely to support their member of Congress if their elected official supported the rebate stacking rule. Non-hospital, community-based infusion centers are seen as being critically important to the healthcare system, and patients and voters believe that protecting them should be a priority for government officials. People like and appreciate infusion centers for their cost effectiveness and improved access to care. Again, if the rule is finalized and infusion centers lose manufacturer discounts, 2/3 of adults are concerned that patients will lose access to the most cost-effective setting for provider-administered medications. Similarly, based on preliminary, soon-to-be published research by Avalere, investigating the implications to supply chain stakeholders, including, in addition to healthcare providers, health plans, PBMs, distributors, GPOs, and pharmacies. 50% of respondents were confident the stacking rule will cause market disruptions, resulting in reduced coverage, choice, and access, higher drug prices, and ultimately additional costs for patients. A health plan respondent stated that rebate stacking will create unnecessary delays and additional costs to be passed on to the end user, which we all know is ultimately the patient or the healthcare consumer. According to a GPO respondent, drug manufacturers will not want to discount their products to the extent they're currently doing so. This impacts the entire healthcare chain, including PBMs, wholesalers, and pharmacies. Pharmacies that are already impacted by changes made to WAC for products like insulin, along with the impending negotiations of tens of products in 2026. Community and long-term care pharmacies and infusion centers especially cannot face a decrease in revenue and reimbursement while sustaining access to care. 2 PBM respondents indicated that ultimately this rule will increase drug prices, reduce coverage, and increase costs that will be passed on to end users, again, ultimately the patient. A wholesaler respondent cited massive changes in the economics of certain drugs will hurt incentives to develop those drugs, creating implications to innovation and subsequent access to a variety of treatments and ultimately consumer choice. Another GPO respondent indicated that this could be the end of our business as far as purchasing discounts. They were not confident that pharmacies and healthcare providers would continue to be in business, causing major issues with our most vulnerable patients not having access to these critical drug services. Ultimately, if this rule is finalized, we will lose community pharmacies, community infusion centers, and other community healthcare providers. We will harm innovation, leading to fewer treatment options for patients. We will ultimately be in a worse situation than we are now, and Medicaid programs, Medicare, and commercial insurers will be left to carry the increased costs as people lose access to treatment and are forced to shift to the emergency department to manage symptoms of unregulated or underregulated disease. That would be an all-lose scenario. That's why patient advocacy organizations should be concerned about this. It's why the National Infusion Center Association has been so heavily involved in getting this rule walked back to protect patient access, coverage, choice, and affordability. And I'll close by reiterating a point I made earlier. It doesn't matter how affordable we make drugs. If we sacrifice access, nobody wins.
Thanks so much, Brian. Very compelling and certainly concerning. Our team put a link to your the morning consult poll here in the chat for folks, and also the bio sketches for all of you. So we'll do Q&A kind of at the end. But next I will introduce you all to Melanie Lendl, Senior Vice President for Policy and Advocacy at the ALS Association. And we'd really like to hear your thoughts from the ALS community perspective on how MDRP might impact access to novel therapies, but anything else that may affect the ALS community.
Sure, and thank you, Michelle, for having me, and welcome to everyone who is new to these coffee chats. It's great to see some of you on screen here, and obviously love to connect at any point in time. I think Brian really covered the basics of this and the concern from any patient advocacy organization. The ALS Association, as I'm sure many of you know, the Ice Bucket Challenge organization, We, of course, one of our priorities is finding better treatments and cures for ALS through research. But one of our other massive priorities, as Brian articulated, is ensuring access and affordability to those treatments as they come to market, as they are discovered. And unless patients can access those treatments, it doesn't matter how much we invest in research. So our concern in particular about this proposed rule is that it could have the impact of reducing access and affordability for people living with ALS. As I'm sure many of you on here today know, ALS is a terminal disease. There are very few treatments available at this point in time. So when we talk about limiting access to even those few treatments that are currently available, it is incredibly concerning for any patient advocacy organization, in particular for a rare disease organization like ours, where patients already have to struggle to get what they need. Our mission is to ensure that every patient, regardless of where they live in this country, how much money they do or do not have, is able to access the highest quality care and treatments, DME, necessary to be able to ensure the best quality of life and quantity of life that anyone can have before this disease ultimately takes them way too soon. So this rule, because it could have an impact on access for people living with ALS, is something we are concerned about, and certainly are voicing our concern with members of Congress.
Excellent. Thank you so much, Melanie. Definitely appreciate that perspective. We will turn now to Ryan Faden. I should have asked how to pronounce your last name, because if it's not Faden, then okay, excellent.
Yeah, you got it.
Who is the Director for Patient Access at the National Bleeding Disorders Foundation. You have an extensive background in working with the bleeding disorders community from both an industry and a patient advocacy standpoint. But would love to hear your thoughts, and maybe start off big picture. Unlike the ALS community, the bleeding disorders community has seen a boom in innovation and has so many treatments available now that weren't available 20 years ago. And so I wondered if you'd reflect on that and sort of the policy challenges moving forward.
Absolutely. Thank you, Michelle, and thank you for having me here today to discuss this really important issue. Before I jump in, I did just want to go back and say definitely agree with Michael's points about the impact that the rule could have sort of on that on the issues surrounding MDRP and access. And I think for everyone, when you kind of think about it, like, oh, like, shouldn't a lower Medicaid best price be beneficial for everyone in terms of patient access? And I think we're showing that the answer is frankly no, because of these issues around access and affordability. Lowering of a Medicaid best price doesn't necessarily, within the current system, doesn't necessarily equal that patients are going to be able to access medications. And of course, for both the National Bleeding Disorders Foundation and the other patient advocacy organizations represented on the call, our chief mission is, as Melanie mentioned, really around ensuring access and affordability for prescription drugs. And I think what I want to do is to discuss sort of the innovation that the bleeding disorders community has benefited from. I wanted to kind of link the issues around the MDRP to what's happening with the implementation of the Inflation Reduction Act, which, of course, the Inflation Reduction Act does have some positive impacts for patient access, particularly around capping out-of-pocket costs for Medicare Part D. So there's definitely some positive things about it, but some of the negative issues around the setting of the maximum fair price are actually in some ways similar to what could happen in the case that these stacked rebates end up being fully implemented. And why is that a concern? The concern is, as has been raised by the industry and others, is the concern around how could that impact innovation. And you know, as Michelle mentioned at the top, there's been a huge amount of innovation that's impacted the bleeding disorders community in a very short period of time. And I just wanted to kind of share a little bit of that story and to think about how maybe in an environment where things like MDRP, discount stacking, rebate stacking, and setting maximum fair prices could have impacted that innovation that occurred. So I think it's important to sort of think about the overall consequences of that rather than just thinking about the price point, which, as we've said, doesn't necessarily equal access. So in terms of the bleeding disorders community, back in the early 1970s, the typical life expectancy of someone with hemophilia was less than 20, which is, you know, so it was really like one of those things. If a child was born with hemophilia, most parents were told not to expect that the child would reach their, you know, 21st birthday. The major advance occurred in the mid-70s with the availability of plasma-derived factor therapies that were able to treat both factor VIII and factor IX deficiencies. Then following the advent of those, we also encountered the HIV/AIDS crisis starting in the late 70s, early 80s, which, as many people know, greatly impacted the blood supply, both for blood transfusions as well as for plasma-derived therapies, which led to some, you know, what I would say is an amazing innovation in a short period of time, where in 1985, the genes for both factor VIII and factor IX were sequenced for the first time, which a short 7 years later led to the first commercial introduction of recombinant factor therapies in 1992, which really was an incredible piece of innovation, both from the standpoint of being able to have purified therapies with lower likelihood of allergic reaction and other untoward sort of consequences. It also led to widespread use of prophylactic treatment, which allowed people to infuse clotting factor before having a bleeding episode. So it basically kept people more healthy and kept their joints in better shape. And then what we've seen since the mid-90s is incremental innovation in recombinant clotting factor that's led to sort of longer acting products have been introduced over the last 10 years, which has reduced the number of overall infusions. And then recently, which I think was really a sea change innovation, was in 2018, a product called emicizumab was introduced, which basically, instead of infusing clotting factor, it kind of tricks the body into thinking that there's clotting factor there. So it's a bispecific monoclonal antibody that basically provides a bridge between factor 10 and factor 10 and factor 10A, which again has revolutionize things in a lot of ways because it obviates the need for patients that can benefit from it, obviates the need for those twice weekly infusions of clotting factor. And then finally, what I would say is just in the last year, we've seen the first introduction of gene therapies for both hemophilia A and hemophilia B. And the uptake has been somewhat slow to date. However, it's a huge decision for people to make. But the fact that we've seen this innovation occur in such a short time, I think, as I was discussing with Michelle yesterday, I think you could really compare hemophilia to almost any other condition, and you wouldn't see that level of impact on life expectancy, quality of life. There's very few conditions that have seen that tremendous impact in a short period of time. And we at NBDF and others would like to see that story be told more, because I think it's really a compelling story of how the importance of innovation. So one thing I would say, just to kind of close, I think that it's where you can really see the importance is we've kind of heard the discussions about the Inflation Reduction Act and how the lack of innovation could lead to, say, I don't have the exact numbers in front of me, but instead of 300 new medications for cancer, there would only be 200. So in the next 10 years, so that's a compelling point. However, I think to kind of bring it home to the general public, I think sort of putting examples around what might the loss of those 100 products actually mean for patients. And I think the more that the space could sort of emphasize that question, I think would be helpful in having those conversations to sort of show the real impact on patients. And I think I'll turn it back to Michelle. Thank you.
Thanks so much. Thank you. So folks, you're welcome to put questions into the chat for anyone on the panel, or even questions that you may have sort of in general. But I'll start off with a couple of questions. And one is that we didn't talk about here necessarily, but one of the provisions of the proposed rule, which is still at OMB, so there's still possibly hope on the horizon, although we are hearing that it will come out very soon, is around patient privacy and the requirement that a patient's diagnosis be listed on the prescription itself. What are your thoughts on that from the panel? Is that something that is concerning, or have you heard about some sort of concerns within your community?
Yeah, I think it is a concern. I think in order to report certain discounts, there needs to be identifiability at the individual level, which raises patient privacy concerns. Absolutely.
We are hearing more that in some communities, maybe more highly stigmatized communities, that this is definitely a concern, but the broader issues, of course, continue to prevail. Another piece, and I was looking through the letter that you all led, Brian, from NICA, that the current methodology enables the community-based infusion centers to offer, you talked about the accessible price, accessible care. But when you look at the proposed rule and think about this new definition of the covered outpatient drug, I wonder, have you all looked at that or have concerns around that? It seems like this would be driving hospitals more patients to hospitals where the definition is more clear.
Yeah, I think it could absolutely drive more drug spend and more patients into hospitals. The broader concern is, if manufacturers are reducing discounts and rebates that they're putting into the supply chain, healthcare providers are among the first on the chopping block, which could extend to hospital care settings, and their appetite and ability to furnish these medications could could be reduced as well. So patients may not have access to hospital care settings, and that access may be limited to, say, 340B covered entities, like DISH hospitals that are covered under 340B, for example, which would drive even more drug spend through the 340B program, which would have, even broader implications for drug pricing downstream as well.
Yeah, thank you for that. And a question about value-based agreements. I know a lot of the innovators, especially in the cell and gene therapy space, have been working proactively with state Medicaid systems to ensure access to the therapies. But how might this proposed rule affect sort of both the operationalization of value-based agreements, but also sort of the incentives behind them?
I could take another stab at that.
Sure.
So I think if we're driving reimbursement below acquisition cost, that is problematic economics, right? No business can sustain losses across a service line indefinitely. And so I think that, sorry, Michelle, I just totally lost my train of thought and lost track of your question. What was your question again?
It's okay. And Ryan, I don't know, you came off of mute. You might had something to add as well, but just about the value-based agreement and, kind of how value-based agreements for some of the most innovative therapies and how the proposed rule might affect those.
Yeah, sorry. Thank you so much. So if providers are losing money on drugs, there's really no appetite to enter into a value-based agreement because there's no access for those products to begin with. Even if it is viable to go into a value-based agreement, I think there are some core concerns about integrating value-based agreements, particularly for provider-administered therapeutics. Essentially, and particularly in the case of when drug is prescribed by an entity different than the care provider that's delivering that medication. Mm-hmm. And ultimately, who's responsible for producing those health outcomes? And when we talk about biologics in particular, there's no one size fits all. It's often a months long, in some cases years long journey of trying different medications and before you find the right medication that effectively manages disease progression and the burden of disease. So in that instance, is it the prescriber that's responsible for those health outcomes? Is it the provider that's responsible? If the provider is entering into these value-based agreements, but they're not responsible for the prescription drug order, they're essentially being penalized if that drug isn't the right drug at that point. So I'm concerned about the appetite for value-based agreements and arrangements in particular in this space.
Sure.
Yeah, thanks, Brian. Yeah, just to sort of can continue with that a little bit. I think when you have the situation where you have the stacked discount reporting requirements and the lowering that would occur to Medicaid best price, I think there would be a clear disincentive among manufacturers to explore value-based arrangements as robustly, if that's a word, as they would otherwise. And I think from the patient standpoint, I think value-based arrangements are in many ways essential. If you look at things like gene therapy in particular, if you look at, say, the handful of gene therapy products that have come onto the market, like the price tags are in the $2 to $3 to $4 million price range for a single infusion, and even though they eliminate potentially the need for further treatment of whatever existing therapy there may be, the concern is, and Brian, you touched on this a little bit, among providers and among health plans, is the financing of that $2 to $4 million price. So the value-based arrangements would allow manufacturers to kind of have, quote unquote, skin in the game so that there could be things like warranty provisions that if the product doesn't work beyond a certain amount of time, that the provider and plan might be entitled to some refund back. So all of those things are kind of incorporated into what the actual cost of the medication might be ultimately. So by sort of changing the existing reimbursement system as it stands, it could disincentivize some of those creative arrangements that could help improve access to those therapies. And I think everybody agrees cost is going to be a big barrier to widespread adoption of a lot of those gene therapies.
Sure.
And I'm happy to chime in here as well from the ALS community's perspective. We know probably the best treatment for ALS at this point in time is getting access to a multidisciplinary care clinic. That is really challenging. But one of the reasons it is so challenging is because the reimbursement levels from Medicare and Medicaid to those multidisciplinary care clinics are below the cost of doing business. So we can't expand the networks without changing the reimbursement rate and without some other private investment as well. So when we think about that and think about the potential ramifications of this rule on top of all of that, it is a perfect storm that creates a horrible situation for people who are just trying to get the care that they need. And we hear it all the time when you're dealing with a rare terminal disease. Care delayed is care denied. That's really what it boils down to. So this is concerning.
Absolutely. And there's a question in the chat sort of related to the value-based agreements and also step therapy, but so I'll kind of parse those apart a little bit. And Melanie, I believe that ALS Association is part of the Safe Step Coalition, working on policy that would ensure that the provider's choice of therapy for the patient is accessible. Do you want to talk a little bit about sort of from both your ALS Association experience, but all your advocacy work over time, what step therapy really means and how it affects the community?
It is a massive barrier to care. Oftentimes we talk about ALS in the sense of we can't wait. People living with ALS cannot wait to be able to receive the best treatment based on the conversations that they have with their individual physicians and clinicians. They can't wait to go through a process where they might try a lower cost therapy or treatment before being given that higher cost therapy or treatment. It's incredibly frustrating, especially when we have so few treatments available. One of the most recent examples we have is step therapy, gene therapy treatment was approved last year through accelerated approval. And it targets specifically one specific type of hereditary ALS that probably only 300 people in the country have. Well, we have patients who are unable to get that because they're being put through step therapy protocols. And this is a treatment that could, based on what we're seeing in the clinical trial data right now, actually halt the progression of the disease. So we're talking about something that's pretty substantial and pretty significant, and forcing patients to try and fail on other of the few out there ALS drugs, not specific for that potential, frankly, life-saving change that we might have here, is incredibly frustrating, incredibly deflating. But it really speaks to the problems that are inherent in our system by forcing people to go through that step therapy fail first process.
And ostensibly, and I guess this might be a question more for Jack than anyone, but ostensibly, if you can enable the value-based agreements up front, you know, that provides sort of provides the runway for access to a given therapy, right? So you don't necessarily have to step through other therapies to get access to that. And yeah, go ahead, Jack.
Yeah, I mean, that's the thing is in terms of step therapy and making sure there's access, you know, it's and I think it was Melanie that said, you know, that care delayed is care denied, and you know, providing access up front is so incredibly important. And I think that, you know, when it comes to value-based arrangements, I mean, the impact of step therapy on VBAs is sort of a strange thing because it could have a completely hindering experience with regard to the VBA, or depending upon the way the manufacturer has negotiated a VBA with the state or purchaser, and it could actually be incorporated in that they allow access to the VBA and not in other ways. So, you know, it's really dependent upon each individual situation, each purchaser and payer in that regard. With that, there is one other thing that I would like to mention though, with regard to the MDRP, and Melanie, you sort of touched upon it in terms of the reimbursement rates, and such, and you know. And Michelle, you mentioned the definition of CODS, the covered outpatient drug definition. And with regard to reimbursement rates, one of the things that's happening in states right now is that there's a trend to start changing to direct reimbursement so that there's higher reimbursement for providers outside of a bundling aspect, which is what's causing these lower rates for the providers, and specialty providers do not want to, you know, start providing gene therapies, cell therapies, and such because they aren't getting enough reimbursement. So this direct reimbursement trend is trying to resolve some of that. And in this change of the covered outpatient drug definition, they are actually saying that if a drug is bundled and it now is identified on an invoice with it, and the state can now claim that as direct reimbursement, and therefore would get a Medicaid rebate. And that would actually incentivize states not to enter into real direct reimbursement outside, and it could actually hinder, you know, the patient access in that regard as well. You know, and there would be no, you know, change or shift in the reimbursement rates, and so that's another, you know, area. It's a nuanced area, but it's actually could have a significant impact on patient access.
Yeah, and the bundled payment idea, then it means that the hospital is not getting directly, to your point, directly reimbursed for the cost of the drug, and so they're likely taking a loss somewhere in the system as a result. And again, if we're thinking about the Medicaid population, we're likely thinking about hospitals that you know, they serve a disproportionate share of uninsured or Medicaid patients. It's a significant hit in those communities. There's a question from Roxanne, who is with the Epilepsy Foundation. And how much is the MDRP a concern for conditions like epilepsy that do not yet have a gene therapy? And I'll let any of you want to take a stab at that. I mean, I think the underlying concern here is that sort of the MDRP layered on top of the IRA, layered on top of, you know, AFPs and PBMs and the alphabet soup we do anticipate that there will be sort of a tightening of that pipeline, or the, chilling of that, some of that innovation. It's hard to quantify that at this point in time, but I think if any of you want to speak to sort of future pipelines.
So I'll just offer one thought. I think it's a really good question, because I think you could sort of you could kind of insert almost any condition into that question and say, well, what's going to happen with X condition where there hasn't been a really effective treatment to date, or that is sort of calling out for new advances like gene therapy. And I think, Michelle, you just said it, that this sort of potential chilling effect on innovation. It's sort of making sure that, I think we've all sort of identified concerns around drug pricing in the US, but it's reforming the system in such a way that allows patients to kind of continue to still have access to medicines, and that the US continues to lead the world in new drug innovation. It's finding that right balance. And so this type of approach that we're talking about here, both, as you said, sort of potential IRA changes to MDRP, et cetera, could sort of orient those incentives in such a way where we don't see some of that, new innovation coming here, and maybe it's coming in another country, or it never happens at all. So I think it's important, as we kind of work with members of Congress and in state legislatures, to kind of think about always sort of, downstream, what are the potential impacts on patient access to both new medicines and kind of the latest medicines that are just kind of entering the market right now.
Thank you for that. So another question that, a lot of times, I think for those of you who may have been around for a really long time, like myself, Medicaid systems, received a 23.5% rebate. That's a long time ago. And then we saw the rise of supplemental rebates. Is there a risk that the MDRP could drive sort of additional supplementals, or raising the incentive to have additional supplemental rebates? And I don't know, Jack, that may be a question for you.
Sorry about that. I was on mute there. Well, I mean, I think that this has a significant impact in terms of how how supplemental rebates would be negotiated. Quite honestly, there would be no incentive, in regard to manufacturers negotiating supplemental rebates, whether or not they be, in VBAs or otherwise. The MDRP rule would have such a chilling effect on that aspect. And then, and because quite frankly, just as we talk about it, the VBAs generally, when it was, I believe it was Brian who was referring to, in terms of the deep discounts, on a VBA, the rule itself does not exempt VBAs, and so and for folks that understand, you all understand how these work, is that you could have a significant discount of, I mean, in some respects almost 100%, but an 80% discount is really a huge discount. For example, on a VBA, well, there are other avenues or channels that this drug may be available to patients, and they might get through a provider that would get a 20% discount elsewhere. So you're talking about 100% that would be stacked on top of that. And in terms of, how the best price would be calculated, and, the drug manufacturer would be essentially giving away the drug, to Medicaid, and that's not something that, is a viable model. So it would have potentially manufacturers potentially withdrawing from Medicaid. And they would have to, as a result, withdraw from Medicare as well. There's, and that's not something we obviously want to see.
Sure.
So, there's a larger context of how this all plays out with VBAs and such. And, but on that basic level, to your question, Michelle, is this supplemental rebate aspect is, there would be, no incentive to negotiate supplemental rebates on Medicaid, even if they were doing the basic rebate of 23.1%.
Thank you. And as I think, Brian, all of you have articulated, this proposed rule will force manufacturers most likely to withdraw other price concessions from the market. So again, across the market, we may see significant price changes and not necessarily for the better. So with all of that, thanks so much for your time. I think I will let ask Melanie to share the last word, just from an ALS community standpoint. What are some of the other, core policies that you are advocating for? Along with, of course, the great work that you're doing here on the MDRP.
Well, I appreciate that, Michelle. Thank you for the last word there. So the ALS Association is, as I mentioned earlier, working on all levels of government, in all branches of government, to try and ensure that treatments and potentially cures for various forms of ALS are developed urgently and as get to market as expediently as possible. And then, of course, a lot of work focused on access and affordability in the ways that we talked about today. A lot of that work, I will say, is occurring mostly at the state level right now. A function of a number of things, not the least of which is some of the gridlock that we're seeing in Congress at the moment. So at the state level, we are heavily focused on trying to ensure genetic protections and privacy for people who choose to get genetic tests. We are also heavily involved in efforts to guarantee access, regardless of age, to Medigap if you are eligible for Medicare, with premium price protections in place, so that it's affordable. Certainly accumulator policy bands, maximizer policy bands, biomarker testing coverage, step therapy, barrier removal, fail first barrier removal as well, and certainly doing everything that we can across the board when it comes to limiting utilization management. And since you gave me the last word, I am going to do a little plug here that I mentioned earlier. We're the Ice Bucket Challenge organization. I know it's hard to believe, but it has been 10 years since the Ice Bucket Challenge. So we are celebrating this May all of the progress that has been made. So if there is anyone who is interested in dumping a bucket of ice on their head again, we would be more than happy to have you do it and videotape you and put it out there on social for everyone to see again. So thank you all for giving me that moment there. I appreciate it.
Excellent. And I'm wearing red just for you. So
thank you, Michelle.
All right. Thanks, everybody. We will see you next time. We really appreciate you spending time with us.